people who joined this time, kind of going over it with the first year guys and realize that this is one of those topics that we need to really keep doing every 6 months, because even though it's very basic, it's very fundamental to what we need to know and do when we're seeing kids with heart disease. So this is, I'll start now. Robin, you're going to record it? I lost Robin. Anyway, yeah, some of them are not being able to record these days because of some space on the server. So I guess for those who are there, welcome. So it's going to be a very fundamentally basic talk on how you determine operability in heart disease, and we'll go over some of the basic lesions like VSDs, and then some of the more complex lesions like transposition, where you have to determine operability. Now, the first, this issue of operability generally arises in older kids. Kids less than 6 months of age, you can make an assumption that they're operable. Now, there are some situations which is your non-regression of fetal pulmonary vascular resistance, where you may be less than 6 months and yet have vascular changes that essentially make you inoperable. But those are quite unusual. Generally, if you're less than 6 months, it's unlikely that you would have become inoperable. But especially in kids over 1 year, especially in older children, adolescents, this is often, an issue. Is the pulmonary vascular disease reversible or not? So let's start with a few basic questions. What is the pulmonary artery pressure in a large VSD? Assuming no pulmonary stenosis, what is the pulmonary artery pressure? So that's right, it's systemic. All agree, if the LV pressure is 100, RV pressure will be 100, PA pressure will be 100. So the pressures are equal. So what determines the left to right flow? What determines whether the shunt will go left to right or right to left? So pulmonary vascular resistance. All clear? Now let me ask you, can you have a newborn? A newborn who has got a large VSD, is their pulmonary artery pressure high or is their pulmonary artery pressure low? So your day 1 of life, all agree? Okay, so we've got, I guess, the senior guys on, but that's right for anyone, whether you're fetal life, newborn or 100 years old. If you have a large VSD, your left ventricular pressure is transmitted to your pulmonary artery pressure, and you have pulmonary hypertension. You will see a lot of adult cardiologists will say, 2-day baby, large VSD, normal PA pressure. That cannot happen. What they mean is normal pulmonary vascular resistance, but PA pressure will be severe pulmonary arterial hypertension. Now, can you have severe pulmonary arterial hypertension and yet have low pulmonary resistance? Severe pulmonary hypertension, low resistance. Can those two occur together? All agree? Yes. Can you have severe pulmonary hypertension and high resistance? Yes. So what determines your left to right flow is really your pulmonary vascular resistance. So what are the signs essentially of low pulmonary vascular resistance? Can you put them down? Just everyone put down all the signs of low pulmonary vascular resistance. Don't put 1, 1, 1, put all the 5 or 6 signs. And I'm not saying symptoms, I'm saying signs, okay? Okay, so fat more than 94, failure to thrive, S3 MDM, increased pulmonary blood flow, cardiomegaly, MDM, features of heart failure, plus HORA, MDM. Okay. Now, when you say signs of CHF, what do you mean by signs of CHF? You mean tachycardia, tachypnea, right? So now when you put here, it's fat 94, that's okay. Failure to thrive is okay. S3 is okay. MDM is okay. But before all that, you need to really be putting what are all the signs of heart failure, which is, what is this? Active precordium, right? Baby may be tachypnic, baby may have retraction, and then when you go and look at the baby still thinks, not gaining weight. When you listen to the baby, that's when you're going to hear your loud second heart sound, and yet along with that an MDM and maybe a systolic ejection murmur. So I think when you are asked what are the signs of low pulmonary resistance, what are the signs that the baby is operable in a large VSD, we need to start with features of heart failure. So baby will be not gaining weight, so baby will have failure to thrive, baby will have an active precordium, retractions, and a liver. When you listen, you're going to have a systolic ejection murmur. And what is the cause of the systolic ejection murmur? What is it? You all have mentioned MDM. I didn't see anyone mention systolic ejection murmur. You've mentioned S3. That's correct. MDM and S3 suggest that increased flow coming back to the left atrium and coming across the mitral valve. But what is the cause of a systolic ejection? What is the importance of a systolic ejection murmur? Yes, it is increased flow across the pulmonary valve and therefore relative pulmonary stenosis. So if in fact you have a baby who has a loud second heart sound, right, that is telling you pulmonary hypertension, and you hear a systolic ejection murmur, even before you hear your MDM, that systolic ejection murmur is a sign of increased flow. So the blood goes LV to RV to PA, so you get systolic ejection murmur, goes through the pulmonary circulation because pulmonary resistance is low, comes back to LA, goes across mitral valve. So then you're hearing the MDM. So you may or may not have an MDM in all patients, but you will have a systolic ejection murmur if they're operable. So I think this is very important when you all, when you're asked, because this is why I wanted to do this class again. Whenever I ask the signs of operability, everybody starts off with MDM and S3. But you really have to go in an organized fashion. There is basically overcirculation. So baby is going to have tachypnea, retractions, a very active precordium. When you palpate a liver, then when you auscultate, then you get your auscultation. Before that, saturation, yes, think, failure to thrive, and then auscultation, systolic ejection murmur with loud second heart sound, and then MDM and S3. Is that clear to everyone? So I think you go in that order. Think, failure to thrive, all the whatever visualization, that active precordium, tachypnea, and then your murmurs. Now, a patient who has these signs of low pulmonary resistance will generally always be operable, right? Now, what are the signs of high PVR? I am asking you for signs. When we say signs, we're not talking yet about X-ray echo. We're talking about signs. What are the signs of high pulmonary vascular resistance? What tells you that, okay, the lungs have been damaged and the VSD is not going left to right anymore and I'm worried about operability? So just write down all the signs in one row. Say I was the examiner and I'm asking you the signs. Start from 1, 2, 3, 4, what you would describe. Okay, see, it's interesting because you're all giving loud P2 as a sign of high PVR. Now let me ask you, if I have a 1-month-old baby who's in heart failure from a large VSD, what will the P2 be? I have a 1-month baby in heart failure with large VSD. What will the P2 be? Loud, everybody agree? Will it be loud or will it be soft? All agree it's going to be loud. Okay. Now let us say I have a 10-year-old with Eisenmenger and a large VSD. What will my P2 be? Loud or soft? still loud, right? So my point here is loud P2 does not tell you if this patient is operable or inoperable. Therefore, when you ask the signs of high PVR, you can't really start with loud P2. You can say he has signs of pulmonary hypertension, which is loud P2, but loud P2 will also be seen in a baby who has a low PVR. So instead of start talking about P2, when you talk about PVR, you have got to talk about other signs. So what are the other signs? Now I see Avinash has mentioned cyanosis and Michelle has said low sat. So the signs of high PVR. So what is happening when the PVR is high? The lungs are damaged, blood is trying to go out to pulmonary artery, but the pulmonary arterioles, the media is very thick. It's not allowing the blood to come. It doesn't want to be banged anymore by this blood. So instead the VSD starts going right to left. So what are the signs? First sign is going to be that precordium that was very active now is very quiet. So your signs are a quiet precordium. Now because the VSD is going right to left, you've got cyanosis. So that baby who was pink is now turning blue. So you have a saturation less than 90%. You have a very quiet precordium because there's no over circulation, right? And this baby is gaining weight. So when you look at the weight, baby is going to be okay. There's going to be no retraction. Baby is not tachypnic. So all the things we said for low PVR, opposite. The signs are low saturation, quiet precordium, non-tachypnic, normal respiratory rate, and then when you take a listen, what are the signs? One is absence of systolic ejection murmur in the presence of a loud P2. Absence of MDM in the presence of a loud P2. Now you may say that this is absence of a sign, but you have to mention when you're talking about a sign, you have a loud P2 and yet I don't have a systolic ejection murmur. So the combination suggests high PVR. So my advice to you would be, if you're in your exam or wherever they ask you signs of high PVR, don't start with loud P2. Start with cyanosis. Say cyanosis, quiet precordium, absence of tachypnea, systolic ejection murmurs and MDM in the presence of a loud P2. Is that clear to everyone? So when you've got this rise in PVR, first the shunt becomes bidirectional. You have signs of cyanosis, no over circulation. And then eventually the patient becomes fully cyanosed because the shunt becomes fully right to left. So let me ask you, when you have a patient with a high PVR, when do you decide he's operable or not operable? What is the gold standard for deciding if he's operable or not operable? How do you decide? Okay, you can look at response to vasodilators. Where do you look? How do you look at the response to vasodilators? How do you decide? Say I tell you patient has high PVR. His PVR is 10. Now how do you decide if he's operable or not operable? So one way is to cath him, right? You take him to the cath lab, you check his PVR. If it's more than how many resistance units are you going to give oxygen? More than? So if PVR is more than 8 resistance units on 100% oxygen, it suggests he's inoperable, right? So the vasodilator that you're using is 100% oxygen. Can you all hear me? Yilkin is having trouble. It may be your bandwidth, Yilkin. So when you have a patient who is cyanosed and has signs of high PVR, this patient may or may not be operable. So before you go to the cath lab, you have to try and figure out what is he operable, is he not operable. So we've done this features, clinical features of operability, heart failure symptoms including failure to thrive, he's pink, O2 sat more than 90%, active precordium, systolic ejection murmur, MDM, gallop, right? All clear on this. Features worrisome for inoperability, sat less than 90%, quiet precordium, no systolic ejection murmur. Now when you have a doubt, so when you're in this category of patients where you're worried about inoperability, you are going to next look at your test. ECG, X-ray and echo, right, to determine. So we're going to look at a couple of these diagnostic tests. Now we've moved from science to your diagnostics. So look at this first ECG on the left. Patient is operable or not? What do you think? And ECG does not tell you really 100%. It just gives you some clues about, what it fits into. So look at the ECG on the left. What do you think? So he has a right axis deviation, right? He's got small r in V1, right axis deviation, but he's got deep S in V6, but he still has a QRS in V6. You see this here? He's got biventricular hypertrophy, right? So he's got right axis deviation, but he's got biventricular hypertrophy. He has a couple of little Q waves in lead 3. Now these Q waves suggest volume overloaded ventricles. He does not have. This patient is borderline. And no, you won't be sure. From the ECG, all you can say is he has got RV. Obviously, his RV is under high pressure, but he's still got some evidence of biventricular. So he could still be operable. Now look at the ECG on the right. He has a pure R in V1. He has some R in V6, so he still has some biventricular forces, but he is predominantly right ventricular forces, and there is no Q wave. So the ECG on the right, you are more worried that this patient is inoperable. But as you can see from ECG, it's not 100%. If you have got Q waves, if you have left atrial enlargement, if you have predominantly LV forces, that would suggest operability. But if you don't have, it doesn't totally mean they're inoperable. On the other hand, X-ray is more useful. X-ray on the left, what do you think, operable or not? X-ray this side, left one. Is it on your left also? Yeah. So operable, why do you say operable? He's got cardiomegaly. He's got plethora, right? Why does he have cardiomegaly? What is the cause of cardiomegaly? Why does he have cardiomegaly? Increased volume overload of what? Of which ventricle? So he's got left to right shunt, I agree. He's got low PVR, but why does he have cardiomegaly? Because the left to right shunt goes back and comes back to LALV. So remember, in a large VSD, which ventricles get dilated? Left atrium and left ventricle. So because of his LALV volume load, he's got cardiomegaly. Now look at the X-ray on the right. Is that patient operable or not operable? What do you think? No. Why do you say no? Because he's got a normal heart size and he's got no plethora and he's got pruning. Everybody sees the pruning? Right? You can see here the cutoff. Vascularity is stopping here. Now he's got a pulmonary artery that's dilated. You all see the pulmonary artery? Now, why is the pulmonary artery dilated? Does that suggest inoperability? The fact that the pulmonary artery is dilated? Does that mean he's inoperable? No, because as we said with P2, loud P2, you can be operable, you can be inoperable. Pulmonary artery dilated, you can be operable, you can be inoperable. But what you have to look at is cardiomegaly, pulmonary plethora, and evidence of pruning, of course. By then you know definitely he's not. But even if he doesn't have pruning, if his heart size has become normal and he has no plethora, this patient is not operable. Okay, all clear on this, right? So now we move to your next, which is your echo. So what are the echo features of operability in a VSD and a PDA? Let's start with the VSD and put all the echo features in one row, not one by one. If I were to ask you this question in an exam, what are the features of operability in a large VSD? What would you start with? What would you end with? So what is the direction of shunt? Okay, so you've got to put all your features, guys. So when you say, if someone asks you what are the echo features, right? First thing that the VSD is going left to right. Okay, that's the first echo feature. So the VSD is predominantly left to right. There may be a bidirectional, that's okay, right? But predominantly, so before you say dilated LALV, say that the VSD is predominantly left to right. Reason being, you got to go in order of what is happening, right? So VSD predominantly left to right, then that blood goes, comes back to LA. So your next statement can be pulmonary venous return increased and LALV dilated. When you have a dilated LALV, that suggests operability. In the absence of mitral regurg or LV dysfunction, you have to always qualify. So when you ask echo features, VSD going predominantly left to right, increased pulmonary venous return, and LALV dilated in the absence of MR and LV dysfunction. Is that clear? These are the main features of operability. Now, the reason I asked you about the cardiomegaly is, can you get cardiomegaly in Eisenmenger? You can, right? And what is the cardiomegaly from there? Not from an ASD test. Say patient has, yes, it's from the right ventricle, right? So when you say cardiomegaly, cardiomegaly has to be associated with plethora for that to be considered an operable X-ray. If you have no plethora and you have cardiomegaly, it could also be more from right ventricular dilation and RV failure eventually. Right? So it's important that the cardiomegaly has to be with the plethora. Similarly here, the VSD has to be left to right, pulmonary venous flow increase, LALV dilated without MR and LV dysfunction. This all will suggest you operability. Okay, all clear on this? All the new fellows who are there? Right? So this point is clear. And this applies to VSD, it really applies to PDA, AV canal. In PDA, you may sometimes see a reversal into the duct. But again, you are looking primarily at the duct. Is it mainly left to right or right to left? Sometimes it's bidirectional, but if left heart is still dilated, that means it's okay. So this is one example. I hope you guys can see it. VSD is predominantly left to right. It suggests definitely operable. Here there's even some turbulence. Now look at this. It's subpulmonic, but predominantly, you see in the second one, there is a right to left. You see the blue, but it's predominantly left to right. So this suggests operability. Here, again it's bidirectional, but if you look at it, it's predominantly right to left. Your LA-AO ratio is not increased. So there's really no LV dilation. This is a more worrisome shunt, right? All see that? Similarly, PDA, you look at these and you say, okay, it's bidirectional, but you get that visual impression that it's predominantly left to right. Look at this one. It's right to left. This is the ductal view. Your hand, it's not your short axis, it's your ductal view with your probe towards your left ear, and it's bidirection, but predominantly left to right. This is just an echo showing you LALV dilation. 4 chambers, a good view. Yes, you can measure your LA-AO ratio, that's a good thing to do. And you can see, look at your interarterial septum, make sure it's slightly, bulged towards the right side. See there, pulmonary artery dilated, that you're going to see in a patient with a large VSD, whether he's operable or inoperable. Just a quick question on this echo, what type of VSD is this? Just a spotter. Keep you all awake. And let it play. Can you see? Not exactly inlet, because maybe you're seeing this artifact, but when you see the AV valve, you don't see much. Then as you tip up, you start seeing it right here. Okay, so it's got definitely subaortic. You could call it subaortic with some inlet extension. What else? What else do you want to say about this VSD? So this is a spotter. You would just be shown this image. It is malaligned, right? So this is the ventricular septum here. This is the aorta. This is the VSD. So if you see, it's a malaligned VSD, but then as you start tipping upwards, what are we doing here? We're tipping up, and you see that there's no pulmonary stenosis. So it's not a tetralogy of Fallot. So it's an overriding aorta, but without PS. So this is a malaligned VSD, also called an Eisenmenger VSD, because when you see this VSD, it is never going to close. And this is the kind of VSD. By what age would you operate? Maximum. How long would you wait? What age would you operate this VSD at? All agree? Any other answers? Any other answers? Not hazarding a guess. Why, Shekhar, you went from below 6 months to ASAP? What does ASAP mean? Say the baby is 2 weeks old, you want to operate? 3 to 4 months. What are you waiting for? Say baby is 1 month old. It's malaligned, right? What are you waiting for? Six weeks, 6 months ASAP. Okay, let's put it this way. The outer limit you would wait, outer limit is 6 months. You would not operate on this baby at 6 weeks. Reason being, he may develop what is called the Guzul's phenomenon. He may develop RVOT obstruction. He may become a tetralogy, right? When you have an anterior deviation of your coronal septum, over time you can get RVOT obstruction. So you would follow this baby and you would operate maximum by 6 months, but this is the kind of kid you want to keep a close eye. If at any time the shunt is beginning to go bidirectional or the symptoms are reducing and he does not have RVOT obstruction, you can operate. So if you want to operate by 3 to 4 months in this kind of baby, that is fine. Definitely not wait beyond 6 months and not keep waiting for him to become tetralogy of Fallot, because they have a high incidence of damaging their lungs. Now, it's called an Eisenmenger VSD because it will never close. It doesn't mean they develop Eisenmengers at 1 month. They are like other VSDs, and you can wait a few months to see if they develop RVOT obstruction. Okay, all clear on that? And this is just an example of impressive pulmonary venous and mitral inflow. Now, when we see this, right, you look at this, you're seeing the pulmonary vein flow is increased. Watch this mitral valve, right? You're seeing, where are you seeing turbulence? Where are you seeing the turbulence? Where is that gradient? So in the supramitral, if you watch this, and I'll stop it for you, you see here, as you play it, just watch. You have the mitral leaflet. I'm going to just annotate that for you. Oh, I can't annotate while it's playing. Okay, sorry. So, I'll stop annotating. So if you see, the turbulence is above the mitral valve, right? It's in the supramitral area. Now, what does that tell you? When it's the turbulence and the flow with the gradient is in the supramitral area. What do you think? What is the cause of that turbulence on echo? Well, you need to rule out a supramitral membrane, but the most common cause of that turbulence in a large VSD is just your increased flow. It's your increased flow coming, and that's why if you get it at the valvar level, you think more of valvar stenosis. When you get it at the supramitral, it's increased flow, and this is what is causing your MVM. Having said that, whenever you see this kind of turbulence, you need to turn the color flow off and look and make sure there is not an underlying supramitral membrane. Okay, but essentially this flow goes along with increased pulmonary venous flow. Okay. Now, one question before we move on. What is the role of contrast echo in the assessment of pulmonary hypertension? What is happening here in this contrast echo? What is your diagnosis here? Watch both these images. Anyone? Diagnosis? PDA right to left. Okay, I get to buy 2 pitch coffee. So when we've injected here, this left side one, when you watch here, when you injected here, you filled RA, you filled RV, but you did not fill LA or LV. So there was no right to left shunt at ventricular level. As you went up, you're looking now, you're looking at the arch, you're seeing some fill. The only thing is it's a little, that is a very delayed fill. That is actually blood, see that one there. Now this one, when you look at it, when you've injected, you're filling down here, right? So when you fill the aorta, without filling the LA-LV, that suggests that's an aortopulmonary shunt somewhere. Now, if it just fills into descending aorta like this one, the second one here, that suggests a PDA. If you get a fill in your ascending aorta, what does that tell you? If you get it higher up, then this could be an AC window. So the importance of when you have pulmonary hypertension and you don't see a shunt, before you just call it CPHN, you need to do a contrast echo. And make sure you're not missing some shunt that's right to left. Okay? All clear on that? Okay. What is the diagnosis here quickly? Potter? What type? Okay, all agree with Kshitij? Any other answers? This is a short axis view. So you see here aorta, and you see pulmonary arteries, you see a connection between the two. So this is a aortopulmonary window, right? And it's between the MCS, so this is a type 1. All clear on this? So in this AP window, the first one is going left to right. In this one, you're worried about it going also right to left. So what are the signs of operability? Echo features of operability in an AC window. And can you put them all in one line? Again, if I were to ask you in an exam, echo features of operability in AC window, what would you be saying? Okay, anyone else for an answer? What are the echo features of operability in AP window? Why is everyone quiet suddenly? So the echo features are the same as the VSG plus diastolic, and Kshitij, you have to specify diastolic flow reversal in the arch. Okay, so we're going to go over that. Now look at this first image. This is your aorta, right? You see the blue flow going down, right? Everyone see that? So that's your normal arch flow. Now watch. This is, you see, this is systole, the blue. Watch in diastole, you see a red signal. Now if you can't see that reversal, you need to turn your Nyquist limit down. Turn your scale down. Now this is the second image. Everyone sees it? Right? So that is your diastolic flow reversal. Now what does diastolic flow reversal tell you? When you see diastolic flow reversal in the arch, I am telling you that suggests operability. That suggests low PVR. Is this clear to everybody? All the new guys, we'll just go over this. Now let us say you have your aorta. You can all see this? A little wait, I'll use a brighter pen. Okay. So this is your aorta, right? Here. Now here you've got, this is your aorta, you've got a connection to your pulmonary artery. Let us say patient has low pulmonary resistance. That means the pulmonary resistance here is, let's say, 5. Okay, in the PH. What is a normal systemic vascular resistance? What's a normal systemic vascular resistance? What's the normal, like when you calculate in the cath lab, what is your systemic vascular resistance? What happened? I'm not asking tough questions, guys. No trick question. What is your normal SVR? Okay, this is homework for everybody. Your SVR can range from 10 to 25, right? So when you've got a CVR of 2 or 5 and you've got an SVR of 10 or 15, your PVR is lower than SVR. So blood, obviously, why should it work trying to go down to your lower body? It would rather come up and path of least resistance. Unlike human beings who fight it, blood goes that way. So that is why in an AP window, the blood will come down come back from the descending aorta, come around the arch. It doesn't mind going a long way and go into the pulmonary artery. So your echo features of operability are essentially going to be again increased pulmonary venous flow, LA-LV dilation, and reversal of flow in the descending aorta. If you have a patient with an AP window who does not have reversal of flow, do not send that patient to the operating room, because you are just going to be operating on an inoperable AP window. Okay, so now let me just ask you from beginning to end, if you can list, if I had to ask you all the features of operability in an AP window, what would you say? Not just echo, from symptoms, signs, ECG, X-ray, echo in one row. I'm just doing this so this helps you think and kind of put down your thoughts in a sequential manner. It will be good if everyone does it, it doesn't matter what the answer is, because it just helps you to put that thought process down when you stop thinking about operability in every baby. My God, you're writing, let's see. Okay, I think so. It's taking time to open up on my system. Okay, so I see here, let me see 1 second. For some reason, I can't see the answers very well, but I see bounding pulse. Okay, good. And that's what I was waiting to hear. So, the features of operability in an AP window is going to be: patient has failure to thrive, has signs of heart failure which includes active precordium, tachypnea, tachycardia, is pink, so has a saturation of more than 90, as bounding pulses. Okay, and this is the difference between an AP window and a PDA and a VSD. On physical exam, if you have bounding pulses in an AP window and a PDA, it suggests that there is a good runoff into the pulmonary artery. It suggests that the pulmonary resistance is low. So bounding pulses are very important in determining operability in AP window and PDA. Obviously, the bounding pulses have to be in the absence of aortic regurgitation. Because if you've got bounding pulse and you have AR, that doesn't count. If you have no AR and you have a bounding pulse with an AP window, bounding pulse with a PDA, you're more reassured that this patient is operable, because that suggests that the resistance is low. So, failure to thrive in a pink baby who's tachycardic and tachypnic, who's got an active precordium, bounding pulses in a liver, and then when you listen to him, he's going to have a loud P2, they're all going to have loud P2s, he hopefully have an MDM, he may or may not, MDM and S3, ECG will show you left-sided forces, Q waves, X-ray will show you cardiomegaly plethora, and echo is going to show you LALV dilation, increased pulmonary venous return, and reversal of flow. So this is kind of the order in which you've got to go to when someone asks you for operability. So the same thing when you say for VSD, you're saying exactly the same thing, except pulses don't matter and reversal of flow doesn't matter. In a duct, pulses matter, reversal of flow is less important because you look very clearly at the direction of the shunt, whether left to right or right to left. Is that clear? Did I miss anything? I'm looking at everyone. So, yeah. So that's good. So you go child, tachypnic. So don't forget the reversal of flow. Okay, because if you ask AP window, what are the other lesions which will give you reversal of flow as a sign of operability, apart from AP window? Name two other lesions where reversal of flow is a very good indicator of operability. Two other lesions. Whoever does it in the next TCS, I buy you lunch. So PDAC, reversal of flow in the, okay, I should have specified, reversal of flow into the aorta, into the arch. The PDA will be much lower down. Okay, hemitrunkus is one. So if you have anomalous origin and trunkus. Okay, Navdeep and Kshitij, you get lunch. So hemitrunkus, where you get anomalous origin of the PA from the aorta, or trunkus in the absence of truncal valve regurgitation. You keep having to, especially when it's trunkus, you always have to specify that reversal of flow in the absence of truncal valve regurgitation suggests operability. Similarly, in hemitrunkus and trunkus, bounding pulses in the absence of AR suggest operability. Patient will be, if he's pink, if you tell me I ask you three things for operability in an AP window. Pink, bounding pulses, reversal of flow. Take him to the OR, no need to catheter. Okay, all clear on this? Okay, so this is just some more, this is showing you reversal of flow in the descending aorta. You can also Doppler it, and so normally when you look from below, you have a flow that's coming, your Doppler is coming towards you. Now you're also going to have reversal with flow going back. Okay, now ASD. ASD is a very different ballgame. We have discussed VSD, PDA, AP window, hemitrunkus, right? Now, in all of them, the shunts are systemic. They are all they all have systemic PA pressures from the get-go. So they all have very early damage of the pulmonary vascular bed, and they all need to get operated very early. So we didn't go over that age of operation. So I think before we move on to ASD, what is the age of operation for an AP window? When will you refer for surgery? AP window. Let's do this in like rapid fashion. Kshitij, I'm taking my lunch back. Not less than 6 months. What is the age? Let's say I diagnose an AP window at birth. When do you want to operate? What does that mean? As early as possible. Why 3 months? Okay. The right answer, guys, is 4 to 6 weeks. Now 4 weeks. You've got to remember this. 3 months is too late. 6 months is too late. The reason is, why is it? Why is it we need to operate by 4 weeks in an AP window, in a hemitrunkus? Why are we operating in a trunkus? Why are we operating by 4, maximum 6 weeks? 4 weeks. Put in your head 4 weeks. PA band 1 month, AP window 1 month. We wait a little bit for the pulmonary resistance to fall. Okay, we wait a little bit for the baby to have fed and bonded with the mother. Okay, so we wait a little bit. Why are we not waiting too long? Why am I saying 6 months is not the right answer, 3 months is not the right answer? Why? Because it's a direct connection between aorta and pulmonary artery. Right? Is that clear? And I'm going to show you that, and I want everyone now to remember this. When I have an aorta, what is the pressure in my aorta? 100 by what? Let's say I have an AP window. What is going to be? I'm going to have a low diastolic, but still I'll have 100 by what you can say 40. Okay. So when I have a large AP window, now it's connected to my pulmonary artery. What is the pressure inside my pulmonary artery? What is the pressure here? 100, right? It's a systemic. And what is my diastolic pressure? Same. All agree? So my diastolic pressure is also 40, right? Now when I have a large VSD, LV pressure is 100, right? Aortic pressure is say 100 by 60. What is my PA pressure in a large VSD? What is my PA pressure in a large VSD with an aortic pressure of 100 by 60? Yes, so it is 100 by, it could be 10, it could be 12, it could be 15, but it's not going to be 60, right? It's not, it could be 20, 30, 12, whatever it is, it's going to be low. In a baby who has low pulmonary vascular resistance, the diastolic pressure in the pulmonary artery is going to be low. So there is no direct banging of the pulmonary artery both in systole and in diastole. Okay, in an AP window, in a hemitruncus, in a large PDA, in a large central shunt, in a truncus arteriosus without restrictive pulmonary arteries, there is systolic as well as diastolic banging of the pulmonary arteries, and that is why they get early pulmonary vascular disease. Okay. In a VSD, on the other hand, there is only systolic banging of the pulmonary artery. So that is why in a AP window, in a hemitruncus, in a truncus, we operate. The other thing is, AP window, hemitruncus, truncus, are they going to get better on their own? Are they going to close on their own? What is the natural history? Never, right? They're never going to get smaller. AP window is not going to close. Hemitruncus is not magically going to get better. Truncus, the pulmonary arteries are not magically in the middle of the night going to go back to the right ventricle. So they are never going to get better on their own, and they are getting banged in both systole as well as diastole. So why wait, right? So you just wait 4 or 5 weeks till PDR drops, till parents arrange finances, till baby is fed a little bit. That's it, and you operate. You don't wait for a wait. You don't wait. If you're waiting 6 months, some of these kids would have damaged their lungs by that time. So it's like closing, after the horse has run away, then you come and close the barn. It's the same situation here. If you wait 6 months, lungs are damaged, then what's the point of closing the shunt? All clear? VSD, what is the age of operation? Large subaortic VSD. When will you operate? Large muscular VSD. When will you operate? Large inlet VSD. When will you operate? Okay, less than 6 months. Okay, so less than 6 months is the right answer. Okay, you're going to wait. Now, why are you waiting? Because it may get smaller. Because the natural history is it may get smaller. So why not give it a chance? If the baby has a lot of heart failure symptoms, not improving with classic digoxin, not gaining weight, you can operate by 3-4 months. If baby's heart failure is controlled, gaining some weight, you can wait to 6 months. Reason being, they're not getting banged in systole and diastole, and the natural history, they can become moderate or small or close. Therefore, that is why we have the difference in management. What about complete AV canal? When are you going to operate? complete AV canal. So the reason, and the right answer is 2 to 3 months. It's not actually 6 months. Reason being, is the complete AV canal going to close? You have to ask yourself that question. If I wait 6 months, will this AV canal improve on its own? No, right? So when the natural history is not going to improve, then why wait till 6 months and have the lungs getting damaged? So therefore, a complete AV canal, you know you have to operate. Yes, you could operate at 4 to 6 weeks. The problem is it's a much more complex operation. You have to create 2 valves out of 1 valve. There may be valve leaking. So you prefer, the surgeons would prefer if the baby is a little bigger. And that's why we wait till 3 or 4 months to let them get a little bigger. So AV canal, different from VSD is that AV canal is never going to improve on its own. So that's why you're not waiting till 6 months. That's 3 months, 2 to 3 months, you can operate. Okay? Now let me ask you, large PDA when we operate. Large PDA. Birth when we operate. Now using the same logic, right? A large PDA may get smaller. That's why we are not saying operate at 4 weeks, right? So even though it is an aortopulmonary shunt and banging the pulmonary artery just like an AP window, a large PDA may get smaller. Therefore, you can push the time when you want to operate. On the other hand, a large PDA is causing both systolic and diastolic hypertension. So it causes earlier vascular damage than a large VSD. Therefore, a large PDA should be operated earlier. I would not personally wait 6 months on a large PDA. By 3 months, 3.5 months, operate. If it hasn't closed, close it off. So you get that difference? Large PDA banging the pulmonary artery like an AP window, like a hemitrunculus, like a truncus. The only difference is large PDA, God may make it a little smaller. You may be lucky and the PDA fully closes. And that's why we give it a little more time. Having said that, you need to follow those babies carefully in the first few months. If you find that the symptoms are disappearing, baby is getting very comfortable, baby is feeding better, baby is gaining weight, but you look at the echo, it's still a large duct, operate. Because that means that now pulmonary resistance is going up. Is that clear? So I think timing of intervention. Large VSD we're giving till 6 months when we know there is a chance of it closing. On the other hand, the large malaligned VSD I showed you, yes, you're waiting till 6 months because you're hoping some RBOT muscle develops. So whenever you're waiting, you should be waiting for something. AV canal, you know it won't close, so operate earlier, 2-3 months. AP window, hemitrunculus, truncus, you know those won't get better. You know the systolic and diastolic hypertension of the pulmonary artery, operate by 4 weeks, 4 to 6 maximum. PDA, you're worried about pulmonary vascular disease, but you're hoping natural history, the ductal tissue may constrict, so you can give yourself again a couple of months. So the difference between management of VSD PDA versus AV canal AP window is that AP window and AV canal will never get better. So you don't wait. PD and VSD may get better, so we give ourselves a little more time. Okay, is that clear, the difference in management? So I'm just thinking it's 6:30, we should probably stop here because I have a whole session on TJ operability. But I would rather do it slowly and so all the new fellows who are in there also get the fundamentals right. So I think we'll stop and I'll just schedule another session to finish this up. So what I'd like you all now, when you're in your OPD to do is to kind of think each time, why am I waiting? Why are we operating? Why am I waiting? Why are we operating? If you have a large VSD, 6 months is not, I want to also say it's not that 6 months means you have to wait till 6 months. 6 months is the outer limit you will wait. That means if baby crosses 6 months and it's still large, you better operate. But if baby is 3 months and still 2 kilos, don't wait. If baby is 3 months and 2.5 kilos, breathing very fast, you maximize lactic, aldactone, digoxin, and yet the baby is breathing fast, not gaining weight. Don't wait. You operate by 2 or 3 months. It's in those situations where baby is relatively doing well, heart failure is relatively controlled, you can wait till 6 months. But at 6 months, take a call and close it off. Unlike situation of large AP window, hemitruncal, no waiting and taking a call. They're born at birth. We say, please plan, come back at 4 weeks, we close it, your life is normal. Okay, so I think with that I shall end, and we will do the rest of the ASD and TJ operability issues in the next session. Thank you all. Have a good evening. Ciao, ciao.